Thank you. Good evening. Welcome. Thank you for attending South County Health's live streaming event, Navigating Healthcare Together, during which various board and executive leadership team members will address the facts behind decisions made. My name is Deb Randall. I am the Assistant Vice President for Quality and Regulatory Compliance at South County Health. As our space is limited, we have chosen to do tonight's community forum on YouTube Live to accommodate a larger audience. This will be recorded and made available on our website. Tonight's event is an opportunity for the community to have their voice heard, and for key members of South County Health's board and administration to provide answers to the questions that community members that you all have. We are going to try our best to navigate a discussion on several topics throughout the evening. Some questions have been summarized in instances where several questions of the same theme have been submitted, and others will be directly as stated in specific form submissions. We will answer as many of the questions as have been submitted as possible in the time permitted. I would now like to introduce our panelists for this evening. Joe Matthews, Chairman of the Board.
Good evening. Yes, I'm Joseph Matthews. And now I have a microphone. It takes a village. I've been associated with South County Health since 1999 when I first started on the VNS, Visiting Nurses Board, eventually becoming the board chair, and then joined the South County Hospital Board for 9 years. In my latest tour of duty, I've been with the board for 4 years as the board chair.
Next is Aaron Robinson, CEO and President.
Thank you, Deb. Good evening, everyone. Again, my name is Aaron Robinson, and I'm privileged to be the president and CEO. I've been with South County Health for about 5.5 years. From a background perspective, I'm a clinician, I'm a physical therapist, and I got my training at the University of Missouri. I'm from the Midwest originally, from St. Louis, and started my healthcare career there. Worked there for many years in multiple roles, starting in rehab hospital and then working my way into the acute care environment, building service lines for a large health system in St. Louis. Oncology service line was one of those service lines. I then was recruited to Florida by some individuals from my former health system for the specific purpose of building service lines in a mid-sized health system in Florida. I built an oncology service line there, also a heart and vascular service line, and then was also CEO of 3 community hospitals in Florida. Spent all of my time on the acute care side of the environment in the community hospital side.
Dr. Anitra Galmore, Chief Operating Officer and Chief Nursing Officer.
Good evening. Anitra Galmore. I have the pleasure of serving as the system's Chief Nursing Officer and Chief Operating Officer. I have been in healthcare for over 30 years now. I am an OB nurse by trade. I started my career as a registered medical assistant, then graduate nurse, and then got into leadership. I served in a community hospital in St. Louis, Missouri. I worked in partnership and collaboration and got a call from an old friend, Mr. Aaron Robinson, who challenged me to come and help co-lead this fantastic organization. I have the pleasure of not only serving as the Chief Nursing Officer and Chief Operating Officer. I live in this community, I serve this community, and I am active on several community boards. Thank you for coming.
Dr. Kevin Charpentier, Chief Medical Officer.
Thank you. Good evening, everybody. As Deb said, my name is Kevin Charpentier. I'm the Chief Medical Officer here at South County Health. By way of background, I'm a surgeon. I spent the majority of my clinical career performing transplant surgery as well as liver and pancreatic surgery, the majority of which was taking care of patients with cancer. I joined the executive leadership team at South County Health in 2002, and one of the big draws for me is this is the first time in my career that I've had the opportunity to work in a community where we have the type of
Let's move right into the topics and then the questions. We are going to be talking about several things this evening, including the Cancer Center, partnerships, quality of care and safety, access to care, standardized appointment scheduling, service line changes, financials and executive compensation, and fundraising. We're going to start with the Cancer Center and the recent resignations. Dr. Charpentier, how would you address Ellie's question? The dramatic and devastating resignations of the oncology hematology medical providers, many of whom have been practicing medicine through South County Hospital for decades, must surely be over much more than an issue of a, quote, for-profit or non-profit, end quote, model of hospital administration. Go ahead.
Thank you, Deb. As we get started tonight, I do just want to thank all the community members who took the time to send in questions. We very much appreciate you doing that and the opportunity to have a conversation and engage in constructive dialogue, so thank you. As it relates to Ellie's question specific to the resignation of the hematology and oncology providers, of course, there's always more details, and I think hopefully by filling in some of the white space, we can clear some of this up. We have been exploring partnership opportunities, certainly during my entire time here at South County Health. One of the areas that we were exploring partnership opportunities was in the service line, in the oncology service line. That is to say, you know, should we remain with a South County Health homegrown program, or was there opportunities to partner with other cancer centers in providing that service? Through that process, Dr. Tabor got introduced, the medical director of the oncology program got introduced to a national organization that stands up and runs cancer programs primarily at community hospitals throughout the United States. She asked that we engage with them to look at what a partnership with them might look like. The executive team was happy to do so. We engaged with them, and over a period of, I think it was probably 6 months or more, we had a series of meetings, and ultimately they presented a proposal to us. Now, I will say that that certainly the medical director of oncology was really very much in favor of moving forward with this partnership, but the executive team was concerned about the proposal that was put forward. They had 4 or 5 tenets to their proposal, one of which was they were going to decrease the square footage of the cancer center in efforts to decrease their overhead. 2, they felt that we were overstaffed in physicians and providers, and they wanted to decrease provider staffing levels. 3, the providers that remained would have to become more productive in order to make their model work. And then they also required a subsidy from the hospital. Perhaps more concerning is that the financial downside risk would be shifted from the organization to the physician. So what that means is, you know, in an employed model like today, where the physicians work for South County Health, in a bad financial year, the physicians still get paid their full salary, and the organization takes on that financial loss. In the model that was put forward from this group, it would the money for any losses would come out of the pockets of the physicians. So the executive leadership team advised against moving forward with that partnership, mainly because the physicians were already feeling like they were overworked in the current state, and so to reduce physicians and forced increased productivity, all while they would be at risk for financial losses, concerned us. There is more to it, of course, as well, right? There were some issues relative to the call schedule that were real, and so the call schedules are managed at the department level by the medical directors. That's not something that's managed by this team or by executive leadership. One of the physicians in oncology was given the summer off of call. And then of the remaining physicians, there was a lot of vacations approved, which is not unusual for us in the summer, as anyone who lives in the community would recognize. And unfortunately, there was a medical leave of absence, and when that medical leave of absence and one of the remaining providers occurred, there really became a shortage of people in the call pool for the oncology program. And it was very shortly after that that we received the resignation of Dr. Tabor, and then the others quickly followed. There is, I think, some misinformation circulating in the community relative to commitments the organization was willing to make in order to support the physicians through that. So hopefully that answers Ellie's question.
Thank you for that detailed explanation. Aaron, given your stated desire to partner with a nonprofit organization for oncology, how does the current partnership with for-profit organizations for orthopedics and gastroenterology differ?
Yeah, I would say the primary difference is that the private practice groups that we partner with, you mentioned ortho and GI, it differs because these are not publicly traded for-profit companies, and the organization that we were looking at potentially partnering, that the oncologist brought forward, is a publicly traded for-profit organization where part of the profits go to shareholders. And we had great concern in putting into the hands of an out-of-state for-profit publicly traded organization charitable community assets, of which we have raised significant amounts of funds from the community. And we felt like, in addition to the risks that Dr. Charpentier mentioned, this organization didn't understand the community well, didn't understand what the community had contributed to the program, and we felt that that was extraordinarily risky and different from the partnerships that we enjoy with those private practice groups.
Thank you. Communications to the patients has also been a hot topic. Ellie also asks, these resignations occurred several months ago. Why has the hospital's executive staff waited this long to defend its decision-making and to protect its patients' continuing care? Dr. Charpentier, can you explain how we've communicated to patients and why some patients are saying they never received communications?
Sure. So how we ultimately communicated to the patients was through letters, and at least 2 letters were sent to every oncology patient relative to what is happening. I think as we reflect back, we see this as an opportunity for improvement, right? So when the resignations from the oncologists came in, I would say that they were abrupt and unexpected. And our first thought was to take some time to work with our employed physicians to see if there was a pathway either to retain them in employment or to work with them to extend their notice period, which would allow for a more orderly transition from one employed oncologist to a new employed oncologist. Unfortunately, as the community knows, we were not successful in achieving that. And then we had to balance sending a message to the community that the physicians were leaving before we had identified the new providers that would be in place to care for the patients versus sending out that communication earlier. We opted to wait until we had a well-formed plan with 3 new oncologists who were going to be joining the team. As I said at the beginning, I think as we reflect back, we recognize this as an opportunity.
Several questions have been submitted on continuity of care. Cheryl asks, Dr. Seidler is my doctor. In his new position, will he still handle my care, or will I be assigned a new doctor? Karen asks, as a patient of Dr. Tabor, who has resigned, can I choose which of the new oncologists will serve as my doctor? Dr. Charpentier, how will the community know who is handling their care at South County Health's Cancer Center?
Yes, thank you. So as it relates to the question regarding Dr. Seidler specifically, when Dr. Seidler returns from his FMLA, which is expected around the middle of October, we anticipate that he will be allotted up to 50% of his time for the medical director role and also to help the new physicians transition into the practice here. That will impact his ability to see his full panel of patients, and we'll work in partnership with him to understand best how to transition patients that may need to establish care with one of the new providers. Additional information will be forthcoming in that regard. As it relates to the transition of care, to the best of our ability, we are going to try to partner with the patients to have as much choice as possible in that regard. Some of the new physicians who come on do have different specialties, and as much as possible, we want to try to align patients with the physician who has most specialization in that area to make sure that we are providing the highest quality of care, which is always most important to us.
Thank you. South County Health has brought on the 3 new oncology physicians, but some patients, including Ellie, have concerns. 2 of the new providers have agreed to 1-year contracts, and the third has agreed to a 6-month contract. Do you honestly think this is good for the patient with cancer to know they may only have the doctor for 6 months to a year? I know as a cancer patient who has been provided the absolute best care. This is stressful, to say the least, and the less unnecessary stress, the better for the patient. I do not want to trust my care to someone who is only there for a year, especially after I have had the best oncologist team already, who truly care about their patients. Dr. Charpentier, what do you say to those patients concerned about losing their cancer provider, maybe for the second time, and may have to transition to another provider in a year from now?
Yes, thank you. So certainly it's not an ideal situation, and so to directly answer the question, do I think that's ideal? I would say it's not ideal. However, it was very important to us that we had no gaps in care. That we
Here, if you have access to a program called 340B, it allows you to purchase your drugs at a 25% discount as compared to programs that don't have that access to that program. And so for us, not having access to 340B, many times the cost of the drug is higher than the actual reimbursement that we get for the drug. So that doesn't even include the cost to provide the space, the staff, all of the infrastructure that we need to provide that service. And so for us, our cancer center, our infusion center was on pace to lose over $2 million. So it wasn't really about maximizing profits, it was about minimizing losses. In addition to our, the deployment of our oncologist, we were up to $3.5 million of loss. So really it was, how do we minimize the loss? And I think it's important to say that, I should have said this from the outset, South County Health, in collaboration with its board, met last year
And moving forward to address the losses experienced in medical oncology and infusion programs.
Well, I think I kind of answered it in my last question. So it's partnership. So partnership is one of our core values as an organization. You mentioned partnerships earlier as it relates to orthopedics, GI services. We've enjoyed many partnerships over the long term that have been mutually beneficial for us and for this community. And we see partnership with a program that has access to 340B, also shares our values, shares our approach to community health, is likely the best path forwards in creating sustainability for our oncology program. Not to mention the opportunity to increase the depth and breadth of access to subspecialists in oncology. As I mentioned earlier, in building these oncology programs, we're a small independent health system, and so we don't have the scale or the volume to employ all the surgical subspecialists, all the hematology oncology specialists, all the research that larger cancer programs have. So partnering with a larger organization in a not-for-profit setting that has access to 340B creates sustainability, and it improves the program.
Thank you. We are having some mic issues, so we are going to have to take a 2-minute break, and then we will be back. And I apologize for that brief interruption. So we were talking about partnerships when we took a break. South County Health has discussed the obstacles they face as an independent healthcare system in Rhode Island. Lori wants to know, is South County Health in conversation with Lifespan? Would it not strengthen South County Health to become part of Lifespan? Joe, many wonder why South County Health remains the sole independent nonprofit hospital in Rhode Island. Why hasn't South County Health merged with another larger health system in the state? What about out-of-state nonprofit organizations?
Thank you for the question. Probably over the last 10 years, the board has considered partnering with other healthcare systems, mostly out of state. Specifically to the question of Lifespan and why that has not occurred, that Rhode Island has, it's not an attractive state to enter into. And so there's not much interest that we see on out of states now considering growing into Rhode Island.
Thank you. This next topic is one of particular interest to me and very important to South County Health. One common theme that is being shared by many concerned community members due to statements made by Dr. Sarah and O'Leary is that the quality of care has suffered due to decisions administration has made. Ken asks, I am scheduled to have surgery at the hospital in November. How can you assure me and other upcoming patients that the patient care will be adequate given the recent turmoil that has been reported in the news? Dr. Charpentier, should the community be concerned about the quality of care that we can expect to continue to receive at South County Hospital?
Yeah, that's a good question. The short answer is no, that there is no reason for concern regarding quality. The quality department on an ongoing basis monitors quality in a number of our programs, and we continue to ensure that we provide safe, high-quality care. In addition to the work that we do internal to South County Health through our quality department, we also submit our data to outside agencies, including to CMS, the Centers for Medicare and Medicaid Services. And they just released their scorecards that they give to hospitals relative to their value-based purchasing program. In that program, hospitals are measured across a number of metrics, some of which include safety and quality and patient outcomes. South County Health continues to be a leader in quality according to the CMS data. We were 61% higher than the average for the state of Rhode Island for hospitals in terms of quality, and we were 100% higher than the national average for quality. And so I think that there's a lot of data that, coupled with our long history of being a Leapfrog A hospital, with few exceptions, and other recognitions by CMS and others, I don't believe that there's any data to suggest that there's any concern for quality of care.
Thank you. One community member referenced a statement from Dr. Farah, who said, quote, "No physicians have left because of inadequate compensation. Most of them haven't fled to Massachusetts or Connecticut. They've gone elsewhere on Rhode Island. Clearly, they're being driven out by management decisions that directly impact their ability to provide quality, safe care to their patients." End quote. Dr. Charpentier, how would you address this statement?
Thank you. I'm really glad somebody asked this question. The assertion that's been made by really a small number of people that a large number of physicians or providers are leaving South County Health is simply not factually accurate. Since 2000, our medical staff has increased by 35%. In 2000, we had a medical staff of 399 members, including both physicians and advanced practice providers. That medical staff has grown today to 539 physicians and advanced practice providers. If we talk about our employed medical group, specifically South County Medical Group, which is a portion of that medical staff, but not the entirety, first we'd want to talk about national benchmarks. The benchmarks nationally for provider turnover range from about 7 to 11% annually, meaning that one would expect that 7 to 11% of your employed provider staff will turn over on an annual basis. When we look at the South County Medical Group over the last 3 years, we've had an 8.9% turnover rate, which is well within the range of expected based on national benchmarks. So again, the assertion that there's been a mass exodus of physicians, it's just not accurate.
Thank you. This past week, a federal investigation took place at South County Health. Dr. Galmore, could you explain further on what led to the investigation and any findings?
Certainly. On September 10th and 11th, we were subjected to a federal survey as a result of an open letter that was shared to the community and with the Department of Health regarding concern for public safety and welfare. We had three surveyors arrive, 2 from the Department of Health and 1 from CMS. This 2-day investigation resulted in absolutely no deficiencies. During the time here, the surveyors had a chance to review our governance structure, our medical staff leadership. They had an opportunity to actually interview all of the executive leadership team, specifically Dr. Charpentier, Aaron Robinson, our CEO, and myself. They had an opportunity to tour key areas of the organization in which the open letter and other misrepresentations from some of the providers that have been mentioned earlier shared were of concern relative to either quality, safety, or the work environment. The areas in which these surveyors toured included our oncology practice, the infusion center, our cardiology practice. They observed the cardiac rehab gym and found that all of these care areas were patient-centric in their design. They were running with uninterrupted service. They had no clinical quality issues. They had no current or anticipated clinical quality or safety issues. So we actually welcomed this survey. Again, it was a deficiency-free survey. And I think Kevin's reference to our clinical quality scorecard would reaffirm our commitment to quality and excellence.
Thank you. A discussion of topic in our community over the past few years has been about doctors versus advanced practice providers, or APPs. A few different questions or comments have been submitted about patients being assigned to see a nurse practitioner or physician assistant, referred to as an APP, rather than seeing a doctor due to the physician shortages that our community is experiencing. One such concern was shared by Diane, who said, "I have now learned that my doctor will no longer do my annual checkup. A nurse practitioner will do it. I want my doctor. I am beginning to feel my care is being compromised by hospital policies. I might be better off with a private practice doctor rather than hospital-sponsored." Dr. Charpentier, what role does an advanced practice provider, APP, play in our health system? Is there a difference in care that an advanced practice provider can offer in comparison to a physician?
That's a great question. So, the answer is that the roles that the APPs play in the delivery system at South County varies by the service line and the specific type of advanced practice provider. So, for example, a PA or a nurse practitioner who's on either the surgical service or the urology service, they function more as a physician extender, helping support the physician team for the work that they do. In other areas, like primary care or express care, it is more likely that an APP would be doing work more equivalent to what you'd see a physician doing, where they would be the provider of record, whether that be for an encounter or in primary care for longitudinal care. Understanding the concern that the question is really getting to relative to quality, I would say a couple of additional things. As the chief medical officer, one of the things that keeps me up at night is the reality is there is a physician shortage. And that physician shortage is not unique to South County Health or to the state of Rhode Island. It's a national issue, and we certainly in the state of Rhode Island are affected. The reality is that if all the health systems in the state, the two biggest health systems, South County and the others, if we all hired as many primary care physicians as we could, it's still unlikely that we would be able to meet the needs of the community simply by hiring physicians. On a national level, what is happening is that APPs are playing a bigger role in care. That is just the reality of the trend. And so if you look at the data nationally for employed providers, national data would suggest, at least from one source, that 38% of providers today are advanced practice providers and not physicians. Because quality is such an important part of our organizational culture, we take our commitment to quality extremely seriously. And we do monitor the quality of all of our providers, whether they be physician or advanced practice providers. And we do have good data, and I'll say that the data source comes from outside the organization, which I think is always reaffirming, that shows that there is no decrement in quality within our medical group between our APPs and our physicians.
Okay. Thank you. One of South County Health's key strategic initiatives is access to care. MJ asks, you have acknowledged that South County Health is the primary health system for residents of Southern Rhode Island. So why did you take South County Health medical primary care doctors out of the southern Rhode Island area and relocate them to points up north? While southern Rhode Island residents are unable to find a primary care provider accepting new patients. Aaron, would you not serve the true southern Rhode Island communities better by keeping South County Health medical primary care providers in our own communities to provide much needed care?
Yeah, that's a great question, and I would just start by saying that we haven't taken primary care physicians out of southern Rhode Island and redeployed them to Warwick or Cranston. What we did in concert with direction from the board was we felt like we needed to serve a broader area of the community to continue to grow our service lines and increase that access. So what we looked at doing was we acquired one practice in Cranston. So these were physicians that were already practicing in that northern part of the community. And then we also hired physicians to start service in the Warwick area, which we continue to hear as more and more patients came to South County Health was a growing need. They liked the care and service that South County Health provided. And so this was an opportunity to increase access for the broader healthcare community, while also increasing referrals to our employed and aligned specialists here at South County Hospital to grow our other service lines, not just orthopedics, but service lines like oncology, service lines like surgery, gastroenterology services, urology. So it was an opportunity to increase access to those services and diversify our revenue, because one of the mandates that I was brought in on by the board was to diversify our revenue and decrease our reliance on orthopedics. Our orthopedic revenue has decreased $10 million over the last few years as they've opened their ASC and as surgeries have moved from the inpatient classification to the outpatient classification. So that orthopedic revenue has reduced over time, while our secondary service area revenue has increased to $35 million just by increasing that access point. So we've diversified our revenue, we've improved access for the broader community, and we've increased the volume to those service lines that do work here at South County Hospital.
Thank you for that. Dr. Charpentier, Karen asks, I was an ER patient last year and I never saw a doctor. Will efforts be made to hire physicians in the ER?
Thank you. Yes, we work constantly in partnership with Team Health, who employs our providers in the emergency room to hire and onboard new providers all the time. As I mentioned in the response to one of my earlier questions, when we look at provider staffing for the emergency room, we do use a combination of physicians and advanced practice providers, and depending on when a patient comes in, what the acuity of their problem is, their provider may be a physician or it may be an advanced practice provider, but we are always continuously looking to recruit and onboard additional emergency room providers, physicians and APPs.
Several questions have come through related to appropriate lengths of time for an appointment, and it is being shared by critics through media sources that the imposition of organizational, quote, benchmarks for patient care visits are being disregarded by the professional judgment of practitioners, who are the best positioned to determine their patients' needs. Dr. Charpentier, what are South County Health's policies around appointment times?
That's another great question, so I appreciate that. I think it's helpful in this question to talk a little bit of background about the structure of the South County Medical Group. So about 2 years ago, working in partnership with the executive leadership team, we created a committee structure within South County Medical Group, the operations committee and the finance committee. And those committees obviously worked on operational and financial issues for the medical group. The committees are a combination of members of the executive leadership team, including some of us on the panel, as well as some others, and also providers. Both there's a number of physicians on those committees, as well as some advanced practice providers, to make sure that we have a representative group of people from the medical group having a voice. We recently combined those committees into what's called the South County Medical Group Advisory Council. So the two committees have now merged into one. Why do I go into all that around a question about appointment times? Our decisions around appointment times are all based on benchmarks, regional benchmarks, national benchmarks. I'll say it first. None of the appointment times that we use are below any of the local or national benchmarks. They're all either at benchmark or longer appointment times in some cases than the benchmark times. But I talked about the committee structure because the decision to move forward with the standardizing schedules came out of that committee structure, meaning that physicians had a voice in those decisions. They voted on those decisions. And when those decisions for the physician schedules were rolled out, they were rolled out with the approval of their physician colleagues from within the medical group.
Gina has a question about current Medicare guidelines for benchmarks. Seeing Medicare is generally the universal guidance. I'm wondering why the physicians did not think this was attainable. Aaron, nephrology is one of the departments that have been referenced in some of the concerns shared by physicians for specific short appointment times, mentioning that administration is asking the nephrologist to limit their appointments to 10 minutes in an effort to increase volume and profits. What is being asked of the nephrologist, and how does that compare to industry benchmarks and also Medicare benchmarks?
So happy to answer this question and clear up what I believe is another example of misinformation out in the community. So as Dr. Charpentier mentioned, there are community standards. If you go to a practice at Brown Nephrology or another nephrology organization within the community, standard appointment times are 30 minutes for new patients and 15 minutes for follow-up appointments. We have worked with our nephrologists to agree to 40-minute new patient appointments and 20-minute follow-up appointments. So this is just another example of misinformation that's being circulated in the community to create anxiety and create a false impression of how we're doing business. So, and all of those appointment times, to Dr. Charpentier's point, are above those community standards. And quite frankly, if you look back at the average of these nephrologists in terms of what they've seen on a daily basis, it's well below those community standards over the past year. So we haven't in the past, nor are we in the future asking them to see anything below community standard.
Okay, thank you. There are a lot of questions and assertions being made regarding recent changes within South County Health's service lines. Let's go through each of those individually, starting with the Center for Women's Health. Denise asks, why was the decision made to cut outpatient lactation services? This is a crucial part for many postpartum women and not something that is usually perfected within the 2 to 3 days spent in the hospital. Dr. Gallmore, can you please speak about the changes in Center for Women's Health, and in particular, changes in lactation within South County Health?
Sure. We actually continue to provide lactation services in a reduced capacity. We have shifted the focus from outpatient to inpatient. All of our mothers and families that deliver at South County Health are offered lactation services. Realizing that some women will need additional services outside of the acute stay, we do refer them to resources that are embedded within the community. Some of these resources actually worked at South County Health prior, and we feel comfortable in their skill and their ability to take care of patients once they've left the hospital. I will say that we continue to provide ongoing breastfeeding classes for the community, as well as new mom courses and classes for the community, irregardless of where they're going to deliver. So we believe that we're continuing to sow and invest in our maternal service line. It continues to be one of our key service lines. That being said, We recognize that this is a change, and as we continue to evaluate all of our service lines, which we do on a regular basis, we will look for other opportunities to optimize reimbursement for outpatient lactation services. Currently, they are not reimbursable because they are included in the global delivery payment.
Okay, interesting. Thank you. There was also community confusion around trial of labor after cesarean, otherwise known as TOLAC, and vaginal birth after cesarean, known as VBAC, offerings earlier this year. Does South County Health offer TOLAC and VBACs? What happened that caused the confusion? Anitra?
At South County Health, we continue to perform TOLAC and VBAC deliveries. Earlier this year, there was some confusion and misinformation in the community that we had ceased this offering. We met with a multidisciplinary team, including our providers, our midwives, our leadership team, our anesthesiologists, and we looked at our protocols and our pathways regarding the care of mothers choosing to do a TOLAC or VBAC delivery. As you're aware, this is a high-risk delivery. We just wanted to reassure that we had evidence-based policies and procedures in place, ensure that all key stakeholders were at the table to be able to weigh in on those pathways. So we currently do provide that service. That being said, I will say that this takes a conversation with the provider as well as the patient. We need to look at medical necessity to ensure the health and well-being of both the baby and the mother, so it's a collaborative decision. We remain committed to our maternal service line. As I stated, we are currently recruiting for additional providers to open up access. We do know we are the birthing center of choice in Rhode Island.
Thank you. Let's talk about the sleep lab. In regard to the changes to the sleep lab, Lorna comments, by taking away the sleep study clinic and home blood draws, you really don't know what the community wants. You are only looking out for pay raises and bonuses, not the community. Anitra, what was the reason for recently discontinuing sleep lab services?
Thank you for this question, Deb. Anytime there's a change in program and services, I just want to reassure the community we do not take this lightly. There are several conversations and several forums up to and including the board. When we make these decisions, we seek to understand the downstream impact that has on our patients, on the community, on our staff, so we don't take it lightly. The care of patients with sleep disorder has actually changed, and there's been a shift. Outpatient sleep services has really moved to home studies, and we saw that in our own data with a decrease in inpatient studies. As a result of that, in addition, we also have some aging equipment. Our sleep service equipment was end of life and end of service, which would require a significant capital investment. So looking at the volume, looking at other resources and partners in the community and their access, the shift to home studies, and the investment that was going to be, the capital investment that was going to be required, we had to make a very difficult decision. As you know, capital is significantly important, and we need to be very strategic in how we begin to make decisions in which we're going to outlay our capital. We also have a competing priority and decided that the best thing to do would be to reinvest that capital in key areas such as our cardiology services based on our patient population. So in early 2025, we will use the capital that we would have replaced the sleep equipment with to put in a new cardiac cath and interventional radiology lab.
So it sounds like you're constantly assessing.
Correct. Thank you.
Moving on to pulmonology, Aaron. It is being reported that there is a critical shortage of pulmonary services, with only one doctor currently managing an overwhelming backlog of patients, a situation that requires immediate resolution. Can you describe South County Health's commitment to pulmonology, and is pulmonology being staffed appropriately?
Well, I would just say that really, if you look across the state of Rhode Island, no specialties being staffed appropriately. There's a shortage of physicians really in primary care and in all major subspecialties. And pulmonology, I think, is the most critically understaffed service, one of the most critically understaffed services at a statewide level. It was one of the primary things that the medical staff was asking for when I arrived here in 2019, after the organization had been unsuccessful in recruiting and retaining pulmonologists in the ambulatory setting. And so we had worked for about a year and a half to find and recruit successfully 2 pulmonologists that came to our organization. One was a sleep medicine physician, and another general pulmonologist and critical care physician. And the sleep physician, contrary to Dr. Farah's assertion, did leave to go to Massachusetts, where the reimbursement was higher. But the remaining pulmonologist that we have has stayed on in her capacity. So compared to when I started, we're still 1 pulmonologist stronger. And we've also hired another critical care physician, pulmonary critical care physician, in our ICU that does shifts with Dr. Bashar Bash. So we are now net 2 pulmonologists and critical care physicians compared to when I started. Just to illustrate the shortage, Dr. Angie Caliendo, who is president of Brown Physicians, Inc., has shared that that is one of their toughest recruits, is pulmonologists. They and they're the director of their sleep medicine program. They have said they have a 6,000 patient waiting list. So it's not just a South County issue; it's a Rhode Island issue, and we're still net better than when I began in 2019.
Thank you. Going back to primary care, we're going to touch on that again. Dr. Charpentier, there are several comments and questions on primary care providers leaving. Why are there no PCPs available? What has led to many PCPs leaving South County Health recently? Some specific questions are related to a group of primary care physicians that left the Woodruff Avenue location and whether that was due to irreconcilable differences with management.
It's a great question. So when I think about the challenges we have, I try to think, is this a South County Health issue or is this an issue with healthcare in general? And this is one of those that's an issue for healthcare in general. There's a problem with access to primary care physicians in the United States, including Rhode Island, including at South County Health. I think that there's a lot of driving factors, probably much more than we can get into in this forum tonight, but just to share a few thoughts, I would say, the primary care is a difficult type practice. It's very hard, and I think it doesn't get the credit for being as challenging as it is. When I say it's hard, what I mean is that in a specialty office, the number of things you have to do to have a successful encounter or visit with the patient is much less than in a primary care encounter. There are many more metrics that they have to meet than the average specialist on an encounter. And that puts tremendous pressure on the physicians to get those things done. The adoption and wide use of electronic medical records over the last couple of decades have negatively impacted both, I think, the patient experience and the physician experience in a number of spaces in healthcare. But I would say probably touched the primary care practices, internal medicine, pediatrics, family medicine, a little bit more. There's an element of how do you get your work done without depersonalizing that exchange, which is really, it's that personal connection that most of us, were drawn to when we went to medical school. And then, reimbursement and pay are issues. They tend to, on the spectrum of physicians, they tend to be lower paid. And so I think a lot of work needs to be done to encourage people to go into primary care, and also for those medical students that train in our state, a lot of work needs to be done to get them to choose to stay in our state to practice upon graduation. I think we've just seen a trend of people, medical students, choosing more specialty practices, fewer people going into primary care practices. And again, that's not a South County Health issue. If you look at the directives of the Office of the Health Insurance Commissioner that came out of the 2004 Healthcare Reform Act for the state of Rhode Island, improving access to primary care was one of those initiatives recognized in 2004. That wasn't a South County Health issue. It's been a state issue and a national issue.
Thank you. And Deborah specifically wants to know if there are any practices or primary care providers that are accepting new patients.
So at a state level, yes, there are, and we're working in partnership with those practices. We recently made a decision to put a pause on accepting new patients while we work through a backlog of patients whose providers have left, and we're working through what's the best way to reassign those currently unassigned patients to new primary care providers. So South County Medical Group currently has a pause on accepting new primary care patients, but several of the RIPIC practices and other surrounding practices do have primary care physicians accepting new patients, and we're working in partnership with those groups to. The most important thing to us is that people get their care, and so if we can provide access to them through a partnered approach, we're happy to do so.
Thank you. Aaron, Janice asks, how are you countering the shift to concierge medicine?
Yeah, it's a great question. And so for those that don't know what concierge medicine is really a shift within the primary care space to address some of the industry issues that Dr. Charpentier mentioned, increasing requirements, challenges with the medical record, underpayments, loss of income. So concierge practices really is a cash-only business. And so a typical primary care physician will see anywhere from 1,500 to 2,000 patients a panel. That's the group of patients that they have, that they see on an ongoing basis. While a concierge physician will see around 300 to 400 patients who pay cash for those services. And so the reason that we've seen a shift to concierge medicine in Rhode Island is some of the payment issues that Dr. Charpentier was mentioning, but in particular in Rhode Island, physicians are underpaid as compared to the national averages. And we actually advocated over the last couple years at the State House for increased reimbursement, not only to hospitals, but physicians, because until such time that they have adequate reimbursement for the services that they provide, then they are going to continue to shift to cash-based practices. So really, I think the best thing that we can do from a state perspective is to improve the reimbursement to those that see larger panels of patients so that they won't have the desire to move into a cash-only business. And so it is a challenging issue because we've seen several physicians in this community move to a cash-only business. In fact, Dr. O'Leary is a concierge physician who only sees patients willing to pay cash.
So cash only then means that they are getting paid more so they can have
Right.
lower
Typically, these are
panels.
wealthier patients that have the ability to pay cash for those services.
Thank you. Cardiology. Aaron, it is being reported by some that administration forced the cardiologists out of their space, and the cardiac rehab clinic was forced to close prior to separating from the hospital. What happened, and why did South County Health end up partnering with Care New England for cardiovascular care, and where are those services located now?
So I think this is a great opportunity to clear up some misinformation. So I would say first and foremost, the cardiac rehab program is not closed. It is open and thriving, and anyone that is interested can go to our lower level and see a full cardiac rehab gym on a daily basis in a brand new space. So, and then I would also say, from a cardiology perspective, we chose to create a patient-centered environment around cardiovascular services and co-locate all of those services on one level. So you as a patient could have access to cardiology services, cardiac rehab, wound care, which requires revascularization, and vascular surgery, all within the same level of our medical office building. These are all brand new Class A spaces, and I think the notion that we've closed those services or diminished those services when in fact we've enhanced them is a prime example of the misinformation that's being perpetuated out there. In fact, when the cardiologists look to transition employment, we partnered with them to say, okay, what are you guys looking for in terms of the reasoning for seeking other employment? And it was multifaceted. There's never just one issue. It was, could we achieve better compensation? Could we achieve a better medical record, a more modernized medical record? Could we achieve a broader continuum of cardiovascular subspecialties that we have access to and that we're a part of as a part of this employment? But could we maintain the patient volume and the patient base that we'd established in this community historically? And we said, look, that all sounds great. How can we work together to achieve that? And the most important thing for us in that conversation wasn't who they got paid by, but that we kept their services in this community. Just like we partner with Ortho Rhode Island for orthopedics, it doesn't matter that they are employed by South County Health. It just remains that it just matters that they remain in this community. So ultimately, what we were able to achieve in this partnership was a more broad continuum of services. What does that mean? So historically, we've had just general cardiologists, and now through the partnership that we've established with Care New England and the Brigham, we have access to a much broader set of subspecialties that can get into electrophysiology or AFib, arrhythmia issues, structural heart issues, and up to and including surgical issues that patients may have. Relative to forcing them into a space that they didn't want to go into, I would just say during this transition to Care New England, we said, look, if you all want your old space, you're welcome to it. You guys are working for a different organization now. If being on the floor you were on before is of utmost importance to you, you can renovate that space. It's still available. Guess what? They elected to stay exactly where they are. And so they had that opportunity. They didn't take it because it was a brand new Class A space on a patient-centered floor, and it made the most sense.
Thank you. Now we're going to move to general surgery. Dr. Charpentier, General Surgical Services has experienced the loss of a surgeon. What is South County Health doing to maintain the critical services that surgeon offered the community?
Another good question. We're doing several things. You've heard a lot about partnerships tonight, and this is a good example of that. Through a partnership with Brown Surgical Associates, we are leasing part of Dr. Julia Tassinari's time, who is a surgeon in the community with a particular interest in patients who have diseases of the breast. And so currently she spends 30% of her time seeing breast surgery patients and performing breast surgery here at South County. In addition, we've explored broader relationships in general surgery and other surgical subspecialties. Those conversations are ongoing. We also are working in partnership with our general surgeons to look at what the best way to staff the hospital for general surgery is. The reality is that if you look over the years, the amount of general surgery volume in the community has gone down year over year for more than 10 years. And so historically, we have a need, or recently we have a need for about 2 general surgeons based on the volume of elective general surgery. However, we have to have at least 4 general surgeons to have a viable call schedule that would meet, people's work-life balance and family needs. And so what that does is it's an overinvestment. There are financial losses in that, but also it drives dissatisfaction amongst the surgeons because they want to be busy. They like to operate. That's why they went into that field. And I think that's a great example of, we have met with our employed general surgeons, I couldn't even count, innumerable times over the last 1 to 2 years to explore a variety of different options as to what the right way to move forward is. We have asked them to consider certain things, and in partnership at different times have made decisions to move forward and to pause in certain areas. So currently we are looking at creating a hybrid model where we would have a surgicalist, which is essentially an acute care surgeon that would take some call, but would not have an elective general surgery practice outside of that, and then have our 2 employed general surgeons in addition to the time that Dr. Tassinari dedicates to South County. And again, we haven't made the final decision to move forward in that direction. However, there's a lot of excitement about that potential opportunity, and so we're encouraged.
So a surgicalist is the surgeon version of a hospitalist.
That's exactly right. That's exactly right. And so they would take proportionally more nights of call in a month, but wouldn't do the outpatient or ambulatory elective surgery portion of the practice. So exactly.
Okay, thank you. Let's talk about urology. Aaron, some community members have expressed uncertainty as to why surgeons in the urology department left to go to Yale New Haven. Could you provide more information specifically with regard to what happened with Drs. Renzulli and Heinemann?
Yes, I'm so glad to be able to answer this question, because this question has come up repeatedly through the years, and I would just say that it's a common misperception that we didn't want to renew the agreement with Dr. Renzulli. Dr. Renzulli is an outstanding surgeon, and we were fortunate to work with him for the period of time that we did. The specific arrangement that we had with Dr. Renzulli was a leased physician arrangement. So he was never employed by South County Medical Group. He was always employed through Yale, and we leased or rented some of his time as the medical director. So he was here for about 60% of his time, and then spent the other 40% at Yale New Haven. And so when his agreement, all agreements have a certain term to them. When his agreement came up, despite assurances from Yale throughout the agreement that they looked to renew it, they decided at the last minute that they did not want to renew it. And we worked very, very hard at that time. I made multiple calls to individuals within their executive leadership at Yale New Haven to ask them to reconsider, because it was a good relationship for us. We had raised money from community assets and through philanthropy to purchase a robot for robotic prostatectomies that he brought to the organization. And so that was the last thing we wanted, was to see him leave the organization. And we tried to convince him to stay on in an employed fashion, but he said what many physicians know in this community is, Aaron, it's a better situation in Connecticut than it is in Rhode Island for physicians for the long term. And he didn't believe that Rhode Island would ever address the undercompensation issues that they had. He also had academic aspirations that made more sense within the Yale system. So we were sorry to see him go. We still think he's a great physician. but unfortunately, despite our best efforts, we weren't able to retain him. The good news is that we have replaced him with a multitude of physicians. We have a female physician, Dr. Caitlin Johnson, who is a Yale graduate that is doing robotic prostatectomies now. She has grown her practice very rapidly and is receiving rave reviews from the community. And we also partner with a private practice group, and they also supplement our urology services here. So we've been able to replace that urology horsepower, if you will, with other members of the community. And we're looking to continue to grow urology services. So that's the history there.
Thank you. Most recently, there were changes to anticoagulation and diabetes management. Anitra, what was the reason for recently consolidating the anticoagulation clinic locations to one office?
Deb, as you are aware, one of our key strategic initiatives is access. In parallel to looking at how we grow and diversify our revenue, as Aaron stated, we have the value of stewardship. And sometimes during those assessments, things are brought forth and we see opportunity for optimization, as was the case with the anticoag clinic. The management of anticoagulation patients has changed. There's different medical management therapies, thus reducing the need for the level of monitoring that is required. We had 3 sites, and we took a look at the site. We took a look at all the patients. We looked at the primary and secondary service area, and we're confident that we could provide service to all of these patients in one location. We had duplication in support services, in pharmacy services, and medical directorships across all 3 sites, and that redundancy was an overinvestment in anticoag, and we have continued to provide that service right here on site and have been able to maintain a level of service and quality to the community that is expected. With regard to diabetes management, we actually had 1 dedicated FTE as a diabetes educator.
And what's an FTE?
Oh, full-time equivalent. 1 dedicated resource, full-time resource for diabetes management. This particular diabetes educator saw anywhere between 3 and 7 patients a day. So we're not talking about large volumes of patients. Once she took a position outside of the organization, we evaluated whether or not we needed to reinvest in that resource or if we could be able to serve those patients in a different capacity, which we were able to do so. With those patients, there are some that are absorbed within the primary care space. We also partner with RIPIC and Integra with other resources that are partnering with us in our primary care space. And our maternal service line was happy to provide direct education services to our gestational diabetics. And as with historical referrals, anyone that we could not service, we would refer to the community partners in a higher risk setting as necessary.
Thank you. You just answered the next question, which was about shifting outpatient diabetes management and education to primary care. So thank you. Aaron, the partnership with Ortho Rhode Island is a very successful partnership for both organizations. Sylvia asks, after South County Hospital renovated its facilities to accommodate Rhode Island Ortho, my understanding is that the majority of knee replacements are done at their own facility as opposed to using the hospital. My understanding is that the hospital is only used when a patient might have to stay overnight. Other procedures are now considered outpatient. Is this true? What advantage for South County Hospital was it to do all these renovations for Rhode Island Ortho and move other doctors out of the second floor if, in fact, they do not even use our hospital for most of their procedures?
Well, it's a great question, and I would just say to begin with, it's been an outstanding partnership with Ortho Rhode Island for many, many years. They have been and continue to be outstanding partners for South County Health and have served this region, the state, exceptionally well. The partnership with Ortho Rhode Island has been successful in growing complex orthopedics here. And what do I mean by complex orthopedics? So when we looked at the future of orthopedics, orthopedics is a rapidly evolving space. So I'm a physical therapist by background, and so I used to rehab patients coming out of getting joint replacements, and that rehab took anywhere from 4 to 6 weeks. Now patients are getting up and walking the next day. There was one patient of Dr. Marchand's that was shooting basketball shots the next day. I think it was his 9,000th robotic joint replacement. So there's been a shift from a largely inpatient procedure to mostly outpatient procedure. And sometimes those outpatients need to stay overnight. And sometimes those patients are complex, where they have a lot of different comorbidities and issues that require the expertise of and the infrastructure of a hospital setting. And so in partnership with Ortho Rhode Island, and based on an older demographic in Rhode Island, we both saw that the demand for orthopedics was going to continue to grow. And so yes, they have shifted some of the lower acuity patients to their ambulatory setting. And frankly, that's not anything different than has occurred in any other community nationally. In fact, what I would say is most of the time when orthopedic groups open up an ambulatory surgery center, they really shift most of their cases out. That has not been the case here. We still do over 3,000 joint replacements here each year. And that volume we have seen grow over the last few years. It's tapered this year, I would say, just a little bit. But I think this partnership has been and continues to be extraordinarily successful, where we look for mutually beneficial solutions, and we both continue to find great success. So I mentioned earlier that our ortho revenue has declined year over year. That's partly because cases have moved out, but it's also partly because the classification of those cases has changed from an inpatient case, where you generally get paid double the amount, to an outpatient case where you get paid about half that we used to. So the profitability has been cut in half as patients have migrated from inpatient to outpatient. And then the lower acuity stuff has gone to the ambulatory surgery center, while the more complex stuff stays here. So again, that's why we've looked with the board to diversify our revenue and grow other service lines as a part of our strategic plan, and not be so reliant on ortho, which we had been frankly over-reliant on as a health system for many, many years.
Okay, thank you. Back to the emergency department, and Dr. Charpentier, to you. George is a longtime resident of Narragansett whose family has come to depend on South County Hospital and their staff for our medical treatments and emergency care. They are now concerned as to the quality and availability of these treatment services. Will the emergency department services and procedures be provided in the future? Will our doctors all leave, and will we have to travel to Providence or Boston for doctors and procedures?
Yes, thanks to George for submitting that question. There's nothing to suggest that we're going to have any change in our emergency services. We have not cut services to any extent. In fact, we're actually growing in the emergency room and seeing more patients year over year over the last few years coming out of the pandemic. And so I think the answer is we're very strong. As I mentioned earlier, we're actually growing as a medical staff, and our turnover rate for physicians is right where we'd expect it. And that's not to say that loss of a physician is not a concern to the organization, a concern to the patients, that physician cares for. However, we're seeing the rate of turnover that we would project and expect, and the goal is always to do better than that. So we're always trying to improve and do better, but there's nothing to suggest that we'll have closure of emergency room services.
Okay, good. Thank you. Home health, Aaron. Gina asks, how do the changes affect home health care?
Well, I would say that home health is a perfect example of what we've been talking about over the last few years. So as you see, we are an older community, and so older individuals use Medicare for their insurance. Well, there's been a shift from traditional Medicare, which generally covers costs in home care, to Medicare Advantage that doesn't cover costs in home care. And so one of the things that we're looking at as an organization between the board and management is how do we create sustainability in home care. Home care, I'm proud to say, is now a 5-star home care agency. So we're a 5-star hospital, and we're a 5-star home care agency. And having worked in post-acute care, I can tell you, overseeing home care agencies and other organizations, 5 stars in home care is exceptionally hard to achieve, both from a satisfaction perspective and a quality perspective. So we're extraordinarily proud of that, and my hat goes off to the home care team for all the great work that they've done. That hasn't happened by accident. And now we're faced with how do we create sustainability from a financial perspective. So again, we have a lot of tough choices to make as a board and as a management team. Our home care agency is projected to lose $800,000 to $1 million this year because of that shift to Medicare Advantage and the underpayments that we keep talking about from a Rhode Island perspective. And so Tom, our Chief Financial Officer, and his team have the extraordinary challenge of trying to negotiate rates that will sustain this critical service to this community. But we're also looking at partnerships that may create a broader scale with local organizations, local healthcare organizations, or even potentially out-of-state organizations that can bring the level of scale that we need to maintain the type of quality and service, but also create sustainability from a financial perspective.
I'd like to comment.
Go ahead.
It's dear to my heart. 3,000 patients we see this year. We'll see this year. Lynn Driscoll, the Vice President of Home Care, and her team have done an outstanding job. One thing in home care, and that's skilled nursing home care, one thing that is not a part of the component is hospice.
Correct.
And this is something, when we talk about partnering, we look I think this is an opportunity, if we're going to partner with somebody, to partner with somebody who also offers hospice, so we can have a more seamless home care experience.
Absolutely.
But here's the issue. From a board perspective, the charge to management is to maintain and exceed our quality performances. Number one. If we're going to do something, we've got to be the best at it. We're not going to do a bunch of stuff and not be the best at those things. And then the second thing is to make sure that whatever we are the best at from a quality perspective is that it is accessible and that it is sustainable. And that's a theme that you've been hearing in this discussion. And I think, candidly, this has been a great opportunity to at least set the record straight on the issues of making decisions about profit. This isn't about profit. This is about ensuring the sustainability for my children and for my grandchildren, to have the same programs and the same services and the same South County Health being available to them. But home care is a particularly challenging opportunity for us, and it has friends on the board. Thank you.
Thank you. There have been a lot of questions submitted around providers. Mary asks, as a physician, MBA, who left Rhode Island to take a leadership position in another state with lower taxes, lower cost of living, and better payer mix, what is your strategy for recruiting physicians and physician leaders back to Rhode Island and to South County Healthcare? Dr. Charpentier, others also want to know what South County Health is doing to entice providers to join and stay with our health system.
Yeah, so recruitment is that we really spend a lot of time looking for fit, skill set fit and cultural fit, right? And we don't necessarily want to take the first person that's available, the first person that applies, but what we really want to try to do is the best we can to try to identify candidates who will commit to our community for the long term. And so I would say at a very high level that has been our approach. However, certainly again, recruitment of physicians remains one of our big challenges.
Thank you. Aaron, Ellen would like to know, what are you going to do to build a better relationship with the healthcare workers, doctors, nurses, and all staff? What are you going to do to ensure we do not lose any more highly qualified doctors?
Yeah, thank you for the question. It's a great question. It's top of mind for us, and I would say that that some of the things that Dr. Charpentier mentioned earlier are important as it relates to some of the changes that we've made in the way that we engage physicians within our medical group. So Dr. Charpentier mentioned the physician advisory group. And so this is a group of physicians that are practicing on a day-by-day basis. And we've invited them to the decision-making table to say, look, we're not going to make changes to your operations without physician input. And so that is really how we've vetted a lot of the changes that have been made. So physicians in each practice have peers that sit at that table, and they can say, why did we move in this direction? Or ideally, those physicians would go back to their peers and say, we are moving in this direction, this is why. That doesn't always happen with busy physicians, and so sometimes things are lost in translation. But that is a structural change that we've made. I would also say that we're looking for more physician leadership. So we've created within our medical group an AVP position over the physician practices that is physician-led. And we are recruiting for that position right now. We actually have a very, very strong candidate. It's a local candidate that we've been talking to. We're hopeful that we can bring that physician to signature on that. So physician leadership is important. With respect to healthcare workers, nurses, staff, we've tried multiple things. And some of the things that we've historically tried have been town halls, presentations. We've gotten some feedback that that's not as ideal from their perspective, that it's not everyone can get away. Sometimes it's hard to sit through a long PowerPoint. Just ask my friend Joe. And so they've asked us to come to them. And so what a lot of the senior leadership team has done is we've gone out and had senior leader rounding where we go to department meetings and we go to them rather than them coming to us. I myself have done some shadowing and rounding with different departments to get a view from the boots on the ground. That was the feedback that we got from folks as it relates to how to get a firsthand view of how things work in different departments. Joe and I also round on a monthly basis. So we get out, we talk to folks, we say what's going on. Joe asks for a number on a scale of 1 to 10, in terms of how they're feeling, and
Then they come back to me and give me all the work. That's how that
this
works.
is true. This is true. She gets it done well, and so with all that said, there's no perfect way to engage, and we're always open for suggestions. I think the level of concern within the community about this misinformation suggests that we have an opportunity as an organization to engage in a different way with our community on an ongoing basis. And we're open to those suggestions as we move forward.
I'd really like to hop in on this one.
May I just interrupt for
Sure.
1 second, though, and just say that we've come to the 7:30 mark, and we are obviously going to keep going, because I think it's really important for the community to hear this information and to get all of these questions that were submitted answered. So go ahead.
Thank you. So my tenure as board chair was during COVID. And one of the experiences that I gained from COVID was the people that I appreciated the most were the cashiers at the grocery store or the people that were running the gas station. And I say that because we need to understand as a community that we have transporters that get you from the ED to your room. You have housekeepers that make sure that your room is in tip-top condition, food service, medical assistants that help with the bookings and the record keeping. This is not just about physicians. We are a community, a ministry of healthcare providing, and it's a team effort. And so it is our responsibility as a trustee, but also as a member of the community, that when you come here, you show the appropriate gratitude and appreciation to have them muscle through difficult days. That is a community responsibility that I'm asking you to share with us. The best part of being the board chair is our rounding. We're known, there are days that people are asking us, I didn't see you last month. I think the employee council said over at Bacon House, where all the finance people are, they feel neglected. We went over there and spent time. And I say this because I see the interchange, the exchanges between this CEO and the people on the floor. I see the interaction with the nurses and him asking you, are you staffed up? Do you have any problems? He says hello to those who help make this place run. And I think the temperature in this hospital, within these four walls, is not being represented out in the public and in the rumor mills and in, candidly, the falsehoods that are being done. I don't see it. I'm here frequently.
Yes. Yes.
I don't see it. And so when it comes to, it's not just the physicians, it's the entire team that works here. I'm asking that as a community, when you come in, you say thank you and show your appreciation, and that will be the strongest retention tool that we have to maintain our staff here.
I would just add that it is extraordinarily disappointing to us, and we had a leadership team meeting with many individuals, and Deb spoke really passionately to this and really well about it last week when we had our press conference. It is hurtful to our staff that they are being misrepresented and the quality of care is being misrepresented within the community to stoke fear and anxiety and paint a picture that is so different from what you see when you walk into these four walls. I will say the surveyors, Deb, you can speak to this, the surveyors we're like, wait a minute, everything's really working well here. We see a high-functioning organization. This is much different than what is being reported in the community. You don't have a continuity of care or an operational issue. You have a perception issue. And that misperception is, I think, despicably being perpetuated by a small group of people that are sowing anxiety. You can see from the questions, are you about ready to close? No, we're not about ready to close. We're in very strong financial condition. Yes, we've lost money. A lot of organizations at our size and scale have lost money coming out of the pandemic. We have 133 days cash on hand, which is more than Lifespan has, more than Care New England has by a long shot. We're in strong financial condition. We're not about ready to go under, and our quality is better than anybody else in Rhode Island. So that it's a different feel when you come in here. And what it's doing is making people second guess whether they want to be here. And when they come to this organization, they're like, wow, this is great.
Absolutely. Yeah, not only the people who work here, but the patients who come here. It works both ways, and it was a very interesting response from those surveyors. They came in very concerned, they didn't know what to expect, and they walked out of here, as you said, no concerns. You have a perception problem that is a misperception.
They expected to find 20 physicians that left in the cancer center, and they said, wait a minute, it was only 3 physicians? Now, we say only 3. We hate, as Dr. Charpentier said, to lose one physician, one APP, any clinician that's providing care to our community. We understand. We have families too. We understand what the care journey looks like for people, and we're saddened when anyone leaves. And we worked extraordinarily hard to keep these providers here, but there will be turnover of physicians in any system. To expect that there won't be turnover in the post-COVID era, especially in Rhode Island, is not based in reality. But it does pain us because of the anxiety it causes. What we're saddened by is the exaggerations and misrepresentations to stoke fear and anxiety and paint a picture of an organization on the brink of collapse. And misinformation is dangerous, as we all know.
Exactly. Thank you. So going into our next
Have a drink of water.
question. Joanne would like to know, are there any plans to bring in a mediator to help resolve a conflict that has spilled into the public sphere and media? I know South County Hospital faces daunting financial challenges, but clearly some of your doctors and nurses do not feel heard. I've lived in the area for 30 years and cannot recall doctors holding press conferences or issuing statements. I fear that other staff feel the same way but are afraid to speak up.
So the board is cognizant of these concerns. We're unclear, candidly, of how well-founded they are. We've spoken about Dr. O'Leary and Dr. Farah, and I'm calling out these names. I've never met Dr. O'Leary. I have invited Dr. Farah and Dr. O'Leary to sit down, just the 3 of us, and I would give them a respectful hearing of what their concerns are. I'm still waiting to hear from them. So when it comes to trying to understand what their issues are, or what the issues are out in the community, the board recognizes that there are concerns. And what we have to do, like we do in everything else in healthcare, is that we want it to be data-driven, not opinion-driven, not the loudest driven, but what are the facts? And so we are setting aside resources as the board in support of making sure that everyone, from the top to the bottom, from the people who come in to receive health care and those who come in to provide the health care, that everyone is treated with respect, that they feel that they are heard, and that they are appreciated. And so we will be taking action, conducting surveys that are designed to understand in a productive fashion what areas people are having concerns or issues operationally in here. It's not just about the physicians. It's about the people that are the caregivers in this hospital system.
I would just say that respect is a two-way street as well. Joe has opened the door to these two physicians who have really stoked most of this misinformation in the community. And I have reached out to them repeatedly to ask if they'd like to come in and have a constructive discussion about what their concerns are. I too have not been responded to, and we've even had others. Dr. Charpentier has reached out to Dr. O'Leary to encourage him to come in and have a constructive dialogue. He won't do it. And so we're left in a position of opening the door, but it takes two people to have a conversation. And so, and as I mentioned at the press conference the other day, I've never even met Dr. O'Leary. Yet he's on a crusade of some unknown origin that he's unwilling to have a conversation around.
Thank you. So Joe or Aaron, what is next? What changes should the community be prepared for?
I get to go first. Thanks.
You're the boss.
Thank you. Our mission is to be your most trusted health partner. The board understands that we've lurched into an area where now people are questioning if we are going to live the mission of being the most trusted health partner. And what we have to do as a board, from a board perspective, is we have to engage the community. Tonight is this video show. We understand that we have to have an interactive forum, public forum, where people can come constructively, ask questions, and have responses similar to what you're seeing here, and to understand what we need to do to regain the trust. We're starting to think about things of how can we communicate better. Right now, and I'll just say that there are some things being considered, and because I don't want to go on for the next 20 minutes. But we do recognize that we have to address concerns and that we have to engage the community better, because we have a hell of a story to tell.
Thank you. Aaron?
Yeah, I would just say that our strategic plan remains the same and has been ratified by our board. I do think that there are ongoing challenges that are, as it relates to what we can do in a sustainable fashion to continue to provide the high quality and accessibility that the board is requiring, but also create the sustainability that we frankly need to make sure that we preserve this mission for many years to come. And so we do have to continue to look at what our core services are, what we can provide on our own, what we might be better able to provide if we've decided it's a core service like oncology that we want to provide to this community, but perhaps through a partnered approach. And I think the unique challenges of the Rhode Island environment require unique solutions and creative solutions. And we are we are consistently and tirelessly pursuing creative solutions to really, really thorny problems in this state. People are tired of hearing it, but it is true. We have got to address the underfunding in this state, not just for South County Health. Ask my colleagues, John Fernandez and Mike Wagner at Care New England and Lifespan. They would say the same thing, not only for commercial reimbursement, but for Medicaid. We are one of the most penetrated states and most expansive states for Medicaid. And Medicaid is underfunded in this state. Commercial is underfunded by 20 to 30%. And that is an unsustainable situation that forces the tough choices that we've had to make over the last couple of years to create that sustainability for those core services. I came here, frankly, to build programs and services, but I also came here to sustain this ministry, and that requires really, really tough choices, and we don't make any of them lightly. We do them through the lens of preserving those critical services that this community needs us to provide on an ongoing basis.
Thank you for that. All right, moving on to financials and executive compensation. Several questions have come in related to executive compensation despite financial headwinds. Joe, can you please describe how executive compensation philosophies are established by South County Health's Board of Trustees?
So, during my predecessor's tenure, the board specifically dealt with the chief executive officer's compensation. And we have an executive compensation committee that makes decisions based on those guidelines at a high level. The base salary of the CEO of South County Health is to be positioned somewhere between the 50th and the 60th percentile of similar hospital systems, healthcare systems. And the full benefit package can be between 60 to 75% of whatever the comps are, comparable compensation packages for other CEOs of like-sized. Annually, we have a consultant, nationally published consultant from New York, comes in, shows his database, the database analysis. They work, I think, 4 or 5 different databases. It's kind of like what's going on with polls. You know, you can't trust one poll. You have to have a group of them. And presents it to the Executive Compensation Committee so that we know where we are in the different ranges. Also, there is discussion about what the trends are in CEO, healthcare CEOs' behavior. Coming out of the pandemic, there was a lot of stress on CEOs, and so typically they were looking for more money up front rather than long-term compensation. And so there would be these kind of discussions just to be aware of it. One of the things at the last executive compensation committee's meetings was, are you looking, when it comes to this particular CEO, are you looking for trying to get commitments for him to try and hang him up for a few years, or you just going to try and work it year by year? One of the considerations in our conversation was we have to refinance our debt. It's about $22 million. And we thought you ought to hang around for that. So that was a consideration in some of our compensation discussions. So the question is, where does the guy stand? Because that's really what everyone wants to know. And that's published in our 990 forms, and the board has approved, in the last month and a half, has approved the release of our 990 forms. But I will share with you, Aaron Robinson's a bargain. his total compensation package is 55% of the median. Now remember, just the base salary should be somewhere between 50 to 60%, and the total compensation package with a window between 60 to 75%. So that's where we are. Have I answered the question?
I think you have.
I would also say, not to speak about me, but just for executive compensation, really for any compensation that we look at as an organization, no one really comes to an organization and says, I want to be paid below market, right? Do your nurses come and say, pay me less than market?
Absolutely not.
Our doctors don't say that.
No.
Nobody wants to be paid less than market. And so that is how we look at all compensation. Maggie would tell you we look at what we call compa ratios, which is really set at the median level of compensation for the organization. So I think the compensation philosophy at the executive compensation level is the same as it is within the organization. We want to pay at market.
Right.
And that is for comparable organizations similar
Correct.
to us.
Right.
They benchmark against similarly sized, similar revenue bases.
Not-for-profit versus
not-for-profit.
for-profit, regional.
It's apples and apples,
Yeah.
not apples and oranges.
Right.
That's very eye-opening. Thank you. South County Hospital was doing great under previous administration. Why all of a sudden, under this administration, you're doing poorly? Aaron, can you please explain the impact? Well, I'll let you answer that question first. Go ahead.
Well, I would say define.
I'd like to answer
Okay.
that. Because I was on the board in the previous administration. And I would say it is a study in different requirements at different times and different leadership for different times. I was not on the board, nor was I on the search committee that chose to hire Aaron Robinson. But I do speak to those people. And the reason Aaron Robinson was hired was because they needed an agent for change. The search committee had determined that whatever had been would not be enough going forward. And they wanted somebody that would be aggressive in pursuing change, transformation, not change, and to ensure ultimately that it was sustainable. I was on the board during the Great Recession when the financial developments adversely and significantly impacted this hospital. There wasn't anyone running around spreading mistruths back then like I see going on right now. But I will tell you, it buckled our knees. And there was, the only thing that was of any advantage was that everybody else was feeling the same pain. But for a small hospital at the time that used a financial engineering that built the Frost Family Pavilion and the changes that we had, because of some of the developments outside of the control of the hospital, we suffered difficulties during that period of time of 2008 to probably 2010, 2011. And back then, there were hard decisions that needed to be made to ensure the ongoing viability of the system. So we all have different memories of how things are. But I was there then, and I'm here now. And I can see what the differences are. Reimbursement rates are different. Expectations of the workforce are different. There's many different items. The demographics of the population we serve are different. It costs $600,000 to buy a house in South Kingston. And we talk about maternity as one of our core service lines. It's hard to be able to afford a $600,000 house. There are big differences that are going on. And I want to assure you, we are as good as we have ever been. And we strive to be better each day, and we strive to be around for your children and for your grandchildren.
Thanks, Joe. I'll just add my 2 cents to it, and I would agree that it's apples and oranges to compare times past to today. I talked about some of it earlier. Several years ago, orthopedics was mostly done on an inpatient basis. Our orthopedic partners didn't have an ASC. They do today. It was pre-COVID in the previous administration. Just as an example, we didn't have a subsidy for anesthesiology multiple years ago, really just a few years ago. And it cost around $350,000 to $400,000 for an anesthesiologist. Now it costs $700,000, and they require $3 million subsidy from the organization each year. Emergency services didn't require subsidy. Now they require subsidy. We have to pay for call that we didn't have to pay for previously. So our physician services investment has grown somewhere around 400% to 600%, just to cover the services of this hospital 24/7, because supply diminished during the pandemic and demand escalated during the pandemic. So cost of services went up dramatically while reimbursement was suppressed. So the math didn't work. And even before the pandemic, our CFO was saying, guys, we're going to lose orthopedic revenue. The costs are growing faster than the revenues. And that's why the board said, when they brought me in, we need to diversify. We need to change. We can't only be reliant on orthopedics. The other thing that has happened over time is we haven't really employed physicians for that long. That may be a surprise to some folks, but we've been in the employment business of physicians for around 20 years of over 100 years of experience as a health system. And so 20 years ago, we didn't have a loss on a physician group. Now that physician loss is $17 million a year. Why did we employ so many physicians? Well, they came to us because they were losing income in the private practice environment. Most physicians don't want to come and say, you be my boss now, right? They come when they start to, their income starts to erode. So the first was OB, then cardiology. Dr. Farah's practice came to us and said, we've lost our income. We need shelter from that eroding income. And then multiple other practices came to us. The hospitalist group used to be a contracted service. Then we brought them in-house. And we hired more and more primary care physicians to serve the community. But all of that comes at a significant loss to the tune of $17 million. Add $8 million for those other contracted physician services, and that's a substantive loss to serve the community that we didn't used to invest in as an organization. And so that's what's different. And in meantime, revenues have not kept pace nearly with those expenses that have gone up astronomically through the pandemic. And those force the tough choices we have today.
So what you're both saying is that different times, different challenges, different financial outlook, different financial picture creates a different or a need for a different management style, and not style, but focus.
Focus, yes.
Yeah.
I would just say the similarity between healthcare here at South County Health, pre-Robinson and now current Robinson, is healthcare is a difficult business. It's a hard business.
There have been 20 hospitals that have closed so far this year, and we're just in September. 34 programs 34 hospitals that have closed programs, mostly OB services. It is not an easy environment these days. And it's not just South County Health. I think folks need to look beyond the towers to see that these issues aren't isolated to South County Health. Look up at all other systems of care in this community. There are many challenges that everyone is experiencing. Primary care shortages, physician turnover, staffing turnover. I will tell you, our staffing turnover is roughly half what our competitors just up the road are. Our nursing turnover is about half of what our competitors is. So we're doing exceptionally well. When you say it's not doing as well as under previous administration, again, I'm a little biased, but I take issue with that because we're still 5 stars. We're now 5 stars in our home care organization. We've weathered an extraordinary challenge in the pandemic as an independent health system and have come out with a strong balance sheet and improving financial performance.
Thank you. So this leads in perfectly to where we're going next. To you, Aaron. Can you explain the impact of rate reimbursement for the state and South County Health specifically? Why did South County Health take the lead within the state, taking this issue to legislatures? What reasons were provided to why the bills did not pass this past legislative session? And what are the next steps? What can the community do?
In 3 minutes or less.
Oh boy. Okay. So we've talked a lot about this, and I would just say again, we believe the issue of recruitment and retaining physicians, nurses, allied health professionals, really all individuals across the teams that provide the comprehensiveness of services in healthcare require parity, equal reimbursement compared to the states that we compete with, Massachusetts and Connecticut. Plain and simple. Joe mentioned $600,000 median home price for folks coming down to South County. That's tough for an environmental services worker or a surgical tech or a floor nurse. And absent sufficient reimbursement to reinvest in the system and to increase our wages to be competitive with Connecticut and Mass, it's going to be an ongoing challenge. So what happened? We have been raising the issue of rate parity at an advocacy level for the last couple years. Mm-hmm. What folks have told me around the state is everybody knows this and it's never going to change. And what we've said as a board and a management team is the definition of insanity is doing the same thing and expecting different results. The math doesn't work here. If you bring in less than your costs, you're going to lose more and more money year over year. That's why 50% of the hospitals in the state have gone bankrupt. Why 2 more sit on the verge of bankruptcy as we speak. It is why the Attorney General has been sounding the alarm about a health system in crisis. People can't find doctors. They can't find healthcare providers, and they're worried about the health of the health system. So we've got to address it. Why did we take the lead? Because we felt like the time was now, and daylight was burning, and we were losing doctors and nurses. Not just South County Health, but all of my brethren up in Providence and across this state. They're complaining about it too. Everybody agreed with the problem, but there was some disagreement on the solution. And so we couldn't, as a hospital association, come together around a solution. I'm happy to say that we, as a hospital association, have agreed not only on the problem, but the proposed solution for our efforts this year. We're hoping to get those proposals into the governor's budget for this coming year. We understand it's going to be a tough budget year, but we're hoping to get those into the governor's budget. And we are united as a hospital association on not only the problem, but the fix to the problem.
I want to jump in here because Aaron's being particularly nice, but the Harry leadership was not up to the challenge. One of the things that this board did was invite the Harry leadership to come down and listen to the concerns that we raised. And we had physicians that were there. We had executive leadership team members that were there. We had the trustees were there. It was a pretty full house. And they were able to see why we were having trouble moving this forward. So there have been some changes in that area. And I'll just finish with this. One of the things that did go right was that we had physician support up at the State House. We had nursing support that came up and spoke to the various committees. So this was an example, at least internally at South County Health, where everyone was pulling in the same direction. And we as the board are appreciative of that. And we have to take those kind of initiatives and use that as a successful template for the challenges that we have now.
Thank you. So we are approaching the home stretch here, moving into fundraising and then some general questions to close. In the current healthcare environment, fundraising plays a large role in South County Health's strategy. However, there may be some misunderstandings, including one patient who says, South County Hospital is a neighborhood hospital, not Warwick Mall. You should not walk into a hospital with a coffee shop and a gift shop looking at you. You want to look at a caring person, compassionate person. Aaron, given recent financial struggles, did South County Health invest in a new coffee shop and gift shop versus investments in technology or the staff?
No is the answer. So, I would say there are two funding sources for those two different projects, and one was Unidyne, which is our partner in food services, as a part of our renewal of their agreement, of our agreement with them. They wanted to bring capital to bear on a different offering of food services for our staff, our visitors, for the community. And, I would say, no, we're not the Warwick Mall, nor do we ever have aspirations to become the Warwick Mall. But we are concerned about providing a welcoming environment to all of those individuals, our staff, our visitors, and the community. That includes spaces like the police entrance that a grateful patient said coming out of the pandemic, he was so grateful for the care that the nurses and the staff, the therapists provided while he was here. He wanted a nice environment for staff to be able to enjoy. Joe remarked about it on our last rounding session. It was a nice day. It's been nice the last few weeks, and that area was full. People getting outside and enjoying the weather. People grabbing a coffee, a nice coffee on the way in or on their break. Staff enjoy that. It is something that they that picks them up and enhances their experience of being here. And that's all part of recruitment and retention, is creating an environment that staff and visitors enjoy. Now to the gift shop. My friend Jerry would take issue with the fact that not all hospitals have gift shops. In fact, we were one of the only hospitals that didn't have a gift shop. And that was one of the priorities.
We had a gift cart.
We had a gift cart. And I will tell you that gift shop and the gift cart provides philanthropy to this hospital, and to the tune of $250,000 at last go around from the auxiliary that Jerry Marlette leads. And a gift shop enhances the ability of that auxiliary to raise money to support the mission of the organization. And the building of that gift shop was built through philanthropy. So we didn't take our operating cash and build a cafe or a gift shop. We took philanthropic dollars to build both of those things, and they've been enormous hits for our staff and the community.
Aaron, who staffs, who staffs the gift shop?
Our auxiliary, our volunteers.
Volunteers. Our volunteers.
Yes.
Staff.
And I will tell you, those volunteers are part of the secret sauce of South County Health. I actually get a lot of compliments. Contrary to what's going on out in the community, they still come in droves. They say from the moment I came to your facility to the moment I left, it was an outstanding experience. And guess who greets them when they come in the front door and who wheels them out or says goodbye to them on the way out? Our volunteers. They are critical to the South County Health experience, and we are supporting them in that. Sorry, Anitra.
I would just say one of the comments stated, are we listening and are we hearing the staff and the providers? And honestly, this has been a long-standing request from our staff. They've been asking for a coffee shop. They've been asking for a gift shop, actually stating, everybody else has one. Why don't we have one? And we heard this over and over again, rounding, when we did our shadowing, through our employee council, through shared governance. So this is in response to their request, and it has been well received.
Thank you. Ellie.
That's a lot of time on a coffee shop.
Yes.
Ellie also asks, has South County Health undertaken any major long-term strategic fundraising or development initiatives in the past 5 years? And if so, have they been successful?
Yes, great question, and I'm proud to say that we have. We have created a Trust and Transformation campaign that's raised $23 million over the last few years. Our goal was 25, so we're almost to our goal. And that Trust and Transformation campaign has funded many incredibly important projects for our organization. And we've renovated our emergency department. We've renovated the waiting room in the emergency department coming out of COVID to create negative pressure, which allows for a better environment that doesn't spread some of the particulate matter that respiratory viruses have. We've created a fast track that allows for treating low acuity patients that we see during the summer months in our ED. We've also created a behavioral health holding unit in our emergency department that really is a nice, healing, and quiet environment for a number of the behavioral health patients that we always have in our emergency. It's the worst place to treat them, but they continue to come in, and so this was a response to that ongoing community demand. We bought a linear accelerator for our oncology program at a cost of around $5 million, a new CT simulator for that radiation oncology program. The list goes on in terms of the ways that this campaign has supported our efforts, and we have not had to burn cash out of our bank account as a result of the successes that we've had in philanthropy. I'm also proud to say last year was the watermark year in terms of the highest funds raised ever in South County Health's history. It was close to $8 million of raised funds last year alone, which was about 40% higher than the closest year to that. We've increased our major donors by about 40% from previous years. And we have programs and services that are connecting with grateful patients and with the community in different ways than we have historically. We're soliciting new individuals rather than going to the same folks over and over and over again. We also have a foundation board and a foundation. So we have come light years in terms of our philanthropic efforts. Are we where we want to be? No one ever is. Tom would love it if that $25 million was $50 million. But I'm very, very proud of the effort that our foundation team has put in and continues to put in a challenging environment to support the organization.
So let's say it's always important to make the best better. And I get what Ellie's asking. I think the foundation, the South County Health Foundation, has to reconstitute itself with a mission to engage the community and to find partners to work with. I think particularly in view of this episode that brings us to this place right now, we can use the South County Health Foundation to help further engage and to explain and to educate and to listen. And I think that's an area, because we can always improve, that's an area where we can do better work. And I think that is certainly something that the Board of Trustees for South County Health and the Board of Trustees for the South County Health Foundation can put a little bit more effort in. And thank you to Ellie for asking that question.
Right, because as Kevin also, Dr. Charpentier also said earlier, we always want to do better. We're always striving for that. Hugh would like to know, I understand you have many challenges, but why are you not interacting and communicating with the general staff? Listening and interacting. Why are you not having monthly financial organizational meetings with the hospital staff to communicate what is happening to the community? Aaron, can you share insights into how executive leadership shares information with staff?
Sure. And it's a great question. I'm sorry that's the perspective out there, but I would certainly challenge the fact that we're not having monthly financial sharing of information. We have a leadership team on a monthly basis where Tom, our Chief Financial Officer, shares the financial results of the organization. We create a leadership to go communication that goes out to all the leaders after we share those financial results, and we ask the leaders to share in each of their staff meetings how we're doing financially as an organization. Really, again, that leadership to go was based on feedback that not everybody can make the town halls or those PowerPoint presentations. So give it to our leaders and get that information out at the staff meetings. Whether they listen when or they hear when the leaders are talking about financials is a different story. You know, a lot of clinicians' eyes glaze over when you start talking about EBITDA and operating margins and financial performance, but it is communicated on a monthly basis to the leaders, who are then expected to go communicate it with their staff. We support that with that leadership to go. We've also done the senior leader rounding, where we go to the departments periodically. They can ask questions about financial performance. Joe and I do our rounding, so we're available. But we're always open to other suggestions. We pivoted in terms of how we were sharing that information previously. We're willing to do that again. We're all ears if there's a better way to do it.
Yeah. Communication is always an issue in organizations, coming from leadership to staff. And, you know, I know that I'm aware, you know, we've surveyed and we've identified opportunities for how we can improve communication. And under that heading of always trying to do better, that's another one that I know we always work on.
Absolutely.
Joe Steve asks, are you planning to offer opportunities for regular people who value the hospital to be able to help make a difference? You're not in this alone, but there is no way I know of how to help.
That's Steve.
Yeah.
Steve, God bless you.
Amen.
A few thoughts. And it all depends on what your gifts and your talents are. If you have spare time, I would urge you to to be a volunteer here and wear that teal vest. If you want to know what's going on in the hospital, you be a volunteer. There are no secrets here. And you're going to make a difference in the experience, the patient experience in that. You'll have to be trained. You have to follow the rules. But that's a great opportunity. If you're somebody who feels that your gifts and talents are understanding, synthesizing information, being a problem solver, at the board level, we have board committees that include community members. Now, you have to be vetted, and you have to understand that you need the broad perspective of accessibility, quality, and sustainability that we've talked about. You can't be an activist for a particular situation. There you are, that's a different kind of cat. And there you have to be vetted. Jason Marshall is the chair of our governance and nomination committee, and we would welcome your involvement there if you have the gifts that will make it different, because this is a very strategic opportunity. The third possibility, that everybody that has taken the time to be here this far into this video program, if you've lasted this long, help us. Help us and talk up this fine institution. If you have a question, we are here. Don't get it secondhand. Come to the source. And while you do that, be an advocate for this community health care system. One way you can do that is write to your local legislators and ask to consider rate parity. You know, I can now tell you, if I get contacted more than a half a dozen times, I know people have a concern. And I want to have you do the same thing as a proponent for South County Health. Give me a couple of beers and I'll think of a couple of more, but those are 3 good starts. And Steve, thank you.
Thank you. And thank you to all the community members that have reached out with their questions and comments. If your questions were not addressed tonight, please know that in the future we have a plan for follow-up community forums, and also all the questions and answers that you have shared will be, not the answers, sorry, the questions and comments that have been shared by you will now be forwarded on to the appropriate leader in the organization who will get back to you. We want to thank you again and encourage you to visit our Addressing the Facts landing page on our website to continue to learn more about the decisions we have made and will need to make in the future. I also want to remind you that there will be a posting of a high-quality recording of this video to our website, and apologize for any of the audio-visual or audio issues in the beginning. The experience will vary according to, the individual internet provider, so we are sorry for that in the beginning. I also want to make a note that there were upwards of 700 concurrent viewers and a total of 2,500 viewers this evening. So thank you. And thank you to all of your willingness to listen and to get the answers.
Thank you.
Thank you.
Thank you, Deb.